Okay. So again, I apologize for having to have this session done tonight. Okay. I've been quite occupied this week with some personal things, and next week as well. In fact, so the people who are supposed to be having PBL with me next week, please contact me to confirm the time and date as well for next week's PBL. Okay, but we have got to get this done. So we'll try to get this done today lah, tonight. Okay, so this evening we are going to cover two things. Okay, the drugs affecting uterine motility. Oh, sorry, I haven't shared this file. Just give me a minute. I'll try to share the file now. You may have the file from last year, but I've updated the files, and the teratogenic files also it's a different file. Teams. Attach. Lectures, mana lectures? Reproductive pharmacology. Yeah, just making sure that I don't send you the questions for the exams. Should be this one. Tekan. Dah banyak kali pula dah. Okay, just give me a few more minutes. Why is it like this? Are you guys seeing my screen?
It's like glitching, isn't it?
Okay, let's try again. Fetch. Once. Preparing file. Okay, should be okay now. Uploading. Alamak, internet is a bit slow. Ada lobby. Okay, it's going. Okay, and send. Okay, so the file has been sent on the meeting chat, so you can download from there and follow the lecture. Okay. All right. So, what are we going to discuss tonight? Okay. The first part is on drugs affecting uterine motility. And if you look at the topic of the lecture, it's actually uterine bleeding and drugs affecting uterine motility. Why do we discuss these two topics together? We used to have a clinician coming in and talking to you about uterine bleeding just for 2 hours, but we thought that it was a bit too much for at year 2 level. You are going to relearn everything that you need to know about uterine bleeding when you actually do obstetrics and gynecology posting in, I don't know, year 3 and year 5, or year 4 and year 5, something like that. Okay, so you will relearn all this stuff. It's just that why we choose to cover it together is because when you talk about drugs affecting uterine motility, and more specifically drugs that cause the uterus to contract, one of the main indications for drugs that cause the uterus to contract is actually uterine bleeding. So that is why we usually talk about these things together. And in fact, tonight I'm going to just cover discuss briefly about postpartum hemorrhage. So it's just a small part of the entire repertoire of things that you need to know about uterine bleeding, because there are other things as well. People who are pregnant, they can bleed in early pregnancy, they can bleed in the middle of pregnancy, but one of the most difficult ones to manage would be bleeding after giving birth, postpartum hemorrhage. As you can see later on, the one of the main indications for drugs that actually cause the uterus to contract is for the treatment of postpartum hemorrhage. So the learning objectives, you can cover the you can look at the learning objectives there. Okay, but the main learning objectives that you need to understand tonight, okay, and when you go back to your books to revise later, is the pharmacology of oxytocic drugs, and the pharmacology of tocolytic drugs. Okay, so I mentioned just now, oxytocic drugs means drugs that cause the uterus to contract. Okay, tocolytic drugs are drugs that cause the uterus to relax. So this one is a different kind of drugs. Okay, they cause the drugs to relax, and they have their own indications. So in a situation where you have the uterus starting to contract to give birth, you may want to actually stop that. Can you think of a situation where we want the uterus to relax? Anyone? What kind of situation would you be in if we want the uterus to relax instead of contracting?
Baby is choking the umbilical vein.
Say again.
The baby is choking on the umbilical cord.
The baby is what?
Choking on the umbilical cord.
Choking on the umbilical cord. Okay. Well, not really. If the baby is choking on the umbilical cord, it is a medical emergency. Good that you brought that up. Okay. If the baby is choking on the umbilical cord, you call the medical term for that. Well, not the official medical term for that, but the medical term for that, at least in the wards and in the labor room, we call that cord round neck. Cord round neck. And that's a cord round neck, and that is a medical emergency, and you definitely want to deliver the baby as soon as possible. So that's no longer about drugs anymore. We just want to cut open the mother. If you want to cut it open, most of the time we need to cut the mother open through emergency cesarean section, and from there deliver the baby. So that good that you brought that up. That is a medical emergency. And other things that can happen with the cord as well, such as cord prolapse. If you haven't heard of the term cord prolapse, you can Google it up as well. When you actually do your ONG rotation later on next year, is it next year or next 2 years? Cord, if anyone hears, if you hear cord prolapse in the ward, everyone will scream and run around because it is an important medical emergency and an urgent medical emergency. So that's another thing, cord prolapse. So two things that we always think about in ONG, cord round neck and cord prolapse. But both of them does not actually involve tocolytic drugs. The situations that you want the uterus to relax, the main indication would be for the treatment of what we call preterm labor. Preterm labor. So meaning if a mother starts to have contractions, not Braxton Hicks contractions. Have you heard of Braxton Hicks contractions before?
Yes.
Braxton. So not Braxton Hicks contractions, but rather strong contractions that that mother seems to be trying to look to be going into labor already. So if you want to terminate those contractions, you don't want the mother to deliver yet. Let's say the baby is only like 20 weeks, the pregnancy is only at 20 weeks, 21 weeks, 22 weeks, 24 weeks. You definitely do not want the mother to give birth yet. So what do we do at that in that situation is we administer the so-called tocolytic drugs. So those are the two different drugs that we are going to discuss in the first lecture tonight. Drugs that act as oxytocin drugs, drugs that contract uterus, and tocolytic drugs, drugs that relax the uterus. Okay, so you would have learned in the in physiology about the process of labor. Okay, and you would have learned that in the process of labor, the mother would start to express more what we call contractile associated proteins, which is basically receptors lah. So we're talking about receptors, and they start to express more receptors, which play a role in uterine contraction. Okay, we tend to differ or disagree sometimes in the mechanism of how these receptors cause uterine contraction, but nevertheless, these are the same receptors that can be manipulated. These are the same receptors that can be manipulated to cause contraction. So if you want to augment the contraction, if you want the uterus to contract even more, you would use a drug that would stimulate, for example, and most importantly, oxytocin receptors. So oxytocin is the main hormone, and if we use it as an exogenous drug, the main drug that can cause um, contraction of the uterus. But other than that, you also have prostaglandin receptors, and also serotonin receptors. So we'll have a look at how some drugs will affect these receptors. So this again is telling you the different uh, hormones and neurotransmitters that are involved in the different phases before the patient gives birth. So you can see here oxytocin and prostaglandin, especially will play a big role during the phase 3, which will give rise to the birth of the baby. Okay, so let's just skip those slides first, and talk about the drugs that cause the so-called oxytocin drugs. So there are just three main drug classes that I want you to go back, open your textbooks and revise. So they are oxytocin, ergometrin, or ergonovin. Some books will use the name ergometrin as the prototype. Some books will use the name ergonovin as the prototype. There are some differences, but basically they are the same lah. So if you see ergo at the front there, you know it's actually the same drug. Okay, and also number 3, prostaglandins. So all these three drugs are drugs that act as oxytocin drugs, drugs that cause the uterus to contract. Okay, you would have learned about the control of oxytocin secretion. So the main stimulus would come from the stretch of the uterus and also the suckling reflex that can cause the release of oxytocin. Okay, and you can see here how oxytocin will act at the cellular level. Okay, so OT here is oxytocin. OT is oxytocin. Okay, so you can see what are the transmembrane signaling mechanism that is being employed. Yeah, but you can see also at the end of the day, it will involve calcium. Okay, and at the end of the day, it will involve the contraction of the muscle that is very much influenced by calcium. Okay, so you can see a few ways that oxytocin can affect this process. The main process is the actual binding to the oxytocin receptor. So you'll be talking about binding to the oxytocin receptor. But remember that there are also effects of oxytocin that go directly to the myosin light chain. Okay, and also the effect of oxytocin on calcium N3 over here. So all this will cause contraction. Okay, so endogenous oxytocin works the same way as what we give as exogenous oxytocin. So when we're talking about endogenous oxytocin, stretch of the uterus cause release of endogenous oxytocin and cause contraction of the uterus to prepare for labor and to prepare for giving birth. But we would still give these drugs if we want the uterus to contract even more. So for the use of oxytocic drugs, okay, there are in fact two main clinical indications. Two main clinical indications. Number one, just now I already told you one of the most common reasons why we need to use oxytocic drugs is because of postpartum hemorrhage. So in a situation of postpartum hemorrhage, we have a situation where the uterus is failing to contract and or not contracting enough after the baby has been delivered. So after the baby has been delivered, the uterus is not contracting enough. And when the uterus does not contract enough, the bleeding will not stop. So the patient will continue to bleed, and that is what we call postpartum hemorrhage. So to stop that problem, to stop that condition, to treat that condition, you administer oxytocic drugs to the patient. Number two, okay, the main indication for oxytocic drugs is their use as drugs that induce or augment labor. So it's either induce or augment labor. What do we mean by induce? Induce means starting the process of labor if it hasn't started when it should have started. Okay, when will a mother start? When would you expect a mother to go into labor to give birth? Anyone? At what week? At how many weeks of pregnancy?
38 weeks.
8 weeks would be the very much the ideal. It would be the ideal time. The cut-off, clinically, the cut-off would be 36 weeks. Anything less than 36 weeks would be considered preterm. So the baby would be considered preterm. And anything more than 40 weeks, 40, anything more than 40 weeks would be considered post-dates. So the medical term that we use is post-dates. Not post-term, post-dates. So if a mother is starting to go over the limit of 40 weeks, if the mother is starting to go over the limit of 40 weeks, one of the options that we have eh, is to induce labor. Mother is already 41 weeks of pregnancy, still no sign of labor, perut dah besar, the uterus is looking very very huge, but still no signs of labor. Mother is also quite relaxed, but also quite nervous. So one of the options, if you want to deliver the baby vaginally, is to induce labor. Okay. Of course, if you don't think labor is a good idea because of whatever reason, then you can also go for cesarean section. So those are the two options lah usually if the baby is post dates. So either you induce labor using an oxytocin drug, or you go for a cesarean section. Okay. So that is one of the reason why we use oxytocin drugs as well. Okay, and the last reason why at least the last main reason why we use oxytocin drugs is to augment labor. To augment labor. Okay, what is the normal duration for a pregnant mother to be in labor? Anyone know? Someone can be in labor for just a few minutes or just a few hours. Okay, if you are already given birth to many children, if you are gravida 9 para 8, for example, so many children already, the body is quite used physiologically to labor, and your next child you can probably deliver it in less than 30 minutes of labor. Very very simple. Okay, but if you have the situation where the patient is having a delayed process of labor, so for example, after 12 hours, still the contractions are very weak, for example, contractions are very weak, no sign of getting into the second stage of labor. So what you need to do, what option do you have? One of the options that you have is you can choose to augment the labor. So remember, physiologically, yes, the patient is already secreting oxytocin. Oxytocin is binding to oxytocin receptors in the uterus to try to contract the uterus. But if that is not happening enough, you can choose to augment, and how you augment, you can use these drugs. In the case of augmentation, it's just number 1 and number 3. So either augments labor using oxytocin or prostaglandin only, not ergometrin. So for augmentation of labor, for induction of labor, yes, you use oxytocin or prostaglandins. Ergonovin, that this drug is exclusively for postpartum hemorrhage. So when you do your housemanship nanti, jangan pandai-pandai bagi ergometrin for induction of labor. You will kill the patient. That is not for induction of labor. Okay. Okay. So about oxytocin, I'm sure you know, probably at this point of time, you know a lot more about oxytocin than myself, because you would have gone through the hormone itself in physiology. So nothing much about it on the pharmacological point of view. Okay. In terms of route of administration, it can be given IV, IM, even intranasal. Okay. Plasma half-life, it has a plasma half-life 5 minutes, so it's given as an if not IM, for IV is given as an infusion. Okay, and it's rapidly metabolized. Okay, and the adverse drug reactions are mainly due to excessive uterine contractions, or because activation of the vasopressin receptors. Okay, right? So think about what happens if you have your vasopressin receptors activated, and why? Because oxytocin, they come from the same part of the pituitary. So you have effects that cause vasopressin receptor activation. And I mentioned just now, the main indications would be for the induction of labor and also for the treatment of postpartum hemorrhage. Okay, let's look a little bit about, I'm just going to show you a little bit about bleeding in pregnancy in general. Okay, since we're talking about postpartum hemorrhage. Okay, so before we talk about postpartum hemorrhage, which is after pregnancy, you can see here how bleeding happens in pregnancy. Okay, and the reasons why there is bleeding in pregnancy. So if it's bleeding at less than 20 weeks, for example, most of the time the reason for bleeding at less than 20 weeks is abortion. Okay, right? Most of the time the reason for bleeding from at less than 20 weeks is abortion. Usually you don't have to give an oxytocin drug after abortion, but sometimes if the mother is bleeding a lot after the fetus has been taken out, or parts of the fetus has been taken out, you may need to administer an oxytocin drug. Okay, but if you bleed um, in the second or third trimester, okay, if you bleed, if you bleed and the bleeding is not from the cervical os, okay, then the cause of the bleeding may be due to something else, infection, vaginal laceration, and in cases like this, it would not be beneficial to give oxytocin drugs anyway, for whatever reason. Okay. If you look at the causes of bleeding in pregnancy in the second and third trimester, the flow chart on the right. Okay. Again, it is divided into bleeding from the os. Okay, or not bleeding from the os. So if not bleeding from the cervical os, it's usually for other reasons. But if it is bleeding from the cervical os, then you have these very important conditions that you will be learning very much when you go for your ONG postings later on. Things that we call placental abruption, or abruptio placenta in Latin, or things such as placenta previa or vasa previa. You can Google that up if you have not actually learned about, nobody has mentioned to you about placenta previa or placental abruption. Eh? Uh, Someone was telling me about preeclampsia the other day during the PBL. So yes, preeclampsia is closely related to um, cases where you get placental abruption as well. So preeclampsia, because of the high blood pressure, you may have a higher risk of getting placental abruption. So in these cases, usually the cases will the bleeding will stop once the cause is identified and treated. Okay, but if the bleeding still continues, then you may also need to stop the bleeding using oxytocin drugs. And this is what I was mentioning to you about postpartum hemorrhage. Okay, many reasons that can cause postpartum hemorrhage. Okay, when you go into your ONG postings later, your professors will ask you to remember what are the 4 T's that can cause postpartum hemorrhage. Number one is tissue, because you have retained tissue in the uterus, for example, retained placenta that will cause bleeding to not stop. Number two is tone, if the uterine is unable to contract, atony, unable to contract, then you will have bleeding. If it's trauma due to lacerations or uterine rupture, so for example, if a mother who has given birth twice using cesarean section and suddenly for the third time she decides to give birth vaginally, that is a very huge risk factor for uterine rupture, not a very good idea. Usually you will try to convince the mother that the best choice is to go for another cesarean section, instead of trying to give birth vaginally, because it may cause uterine rupture and that will lead to postpartum hemorrhage. And of course, the other T is due to clotting. So if there are coagulopathy conditions of coagulopathy in the mother, that may impair the process of blood clotting, and it may cause bleeding to continue. And you may have to administer oxytocin drugs to the mother as well. But in actual fact, in this condition, you may need to give things such as fresh frozen plasma, and other drugs, other substances that can help cause clotting, because there is a failure of clotting in the patient. Okay, so you can actually go through this flowchart from the Calgary Guide. Okay, I think it's a very good um, summary. It's a very good summary of the causes of postpartum hemorrhage. And all these conditions may warrant the use of oxytocin drugs. Okay. Now this is a CTG. Okay. Anyone have gone through with you a CTG in this block?
Not yet, doctor.
Not yet. No one has talked to you about the CTG. So if you are monitoring a mother during labor, if you are monitoring a mother during labor, this is the method of monitoring. This is called a CTG. So for cardiology, cardiological diseases, you monitor a patient using ECG. For ONG, you monitor a patient using CTG, cardiotocograph. Cardio, the top part here is the heart rate of the fetus, the fetal heart rate. And the bottom part there is uterine contractions. Uterine contractions. So you can see here uterine contractions 2 in 10 minutes. If it's early stage of labor, uterine contraction of 2 in 10 minutes is quite okay. But if the patient is starting to have prolonged labor and the uterine contractions is still only 2 in 10 minutes, then you may want to consider augmentation of labor, for example. Okay, and all this must be looked at together with the fetal heart rate. Fetal heart rate is normal to be variable like this. This is what we want, variable heart rate. variable heart rate. This is a normal reading. If it's not very variable, straight line, something like this, then that is not normal. Or even worse than that, sometimes you have decelerations. So the graph will look something like this. Decelerations that now I'm getting a bit beyond what you need to know at second year, but just just try to keep up with me lah. Okay, decelerations, if it is synchronized with contractions, it's normal. Decelerations that synchronize with contractions, they are considered normal. Because you can imagine lah, baby inside the womb, if the uterus is contracting, of course lah, the heart rate will decelerate a bit because you are getting compressed in there. So that's normal. But sometimes you get decelerations that do not synchronize fetal heart rate decelerations that do not synchronize with the fetal heart rate. The fetal heart rate does not synchronize with the contractions. So that is a sign of a problem. That is a sign of a problem, and we call that fetal distress. Okay, of course you can Google this up if you are interested. At this point of your lives, it's nice to know. Later on in ONG, then it's considered need to know. For now, it's nice to know lah. So that's called fetal distress. When you have multiple fetal heart rate decelerations, and that is a sign of a problem in the baby, and you need to make a decision. Usually, the baby will need to be delivered. So you need to think about it. Do we proceed with vaginal delivery, or do we have to proceed with an emergency cesarean section? Okay. Okay, so the other drugs that can be used as tocolytic drugs, and here we have your prostaglandins. Okay, prostaglandins, and you can see here the mechanism of action is pretty much the same. So they stimulate different receptors, but they act on similar. Okay, they act on similar transcellular signaling mechanisms, and that cause contractions that are facilitated by high levels of calcium. Okay. All right. So prostaglandins that are used for um, induction of labor, augmentation of labor, not so much for postpartum hemorrhage. So these three drugs, they are the main drugs that are used for induction or augmentation of labor. Okay, so again, the main mechanism here involves calcium. Okay, and in terms of adverse drug reactions, you don't have to worry too much. You have things such as nausea, vomiting, diarrhea, fever, all those things. We're not worried about these adverse effects. Okay. Okay. So number one, oxytocin. Number two, prostaglandin. Number three, ergonovin or ergometrin. And this one, its use is exclusively for postpartum hemorrhage. Postpartum hemorrhage. How does it act? We are actually not very sure. Actually, some of us are sure lah, but we do not agree on. I mean, pharmacologists do not agree lah in terms of how they actually work. But if you read most textbooks, they will mention that their mechanism of action will involve partial agonism at alpha adrenergic receptors, dopaminergic receptors, serotonergic receptors. Remember alpha adrenergic receptors? So there are alpha adrenergic receptors at uterine smooth muscle. Okay. And stimulation of these receptors are thought to mediate the process of contraction. And similarly, dopaminergic receptors, there are some receptors that are thought to be able to directly influence contraction or through a slightly longer mechanism by increasing levels of noradrenaline, okay, and stimulating adrenergic receptors, eh, or even serotonin. Yeah, so don't worry too much lah. Just know that there are multiple receptors that are postulated to be involved. Okay, but they will this drug will induce tetanic contractions of the uterus. Eh? Tetanic contractions, it means that they are very strong contractions, hence why they are very useful for the treatment of PPH. Eh? Very useful for the treatment of PPH. Okay, and unlike oxytocin or prostaglandins just now, use of these drugs, we have to be a little bit more careful, or even a lot more careful, in that there may be problems such as vasospasm, cerebral ischemia, or ischemia of the extremities. Eh? Vasospasm, cerebral ischemia, or ischemia of the extremities. These are all related lah. So the cerebral ischemia is due to vasospasm. The ischemia of the extremities is also due to vasospasm. And the reason why we think that is the case is because they stimulate alpha adrenergic receptors. So I hope you remember our blood vessels, they also have alpha adrenergic receptors. And if those alpha adrenergic receptors are stimulated, your blood vessels will contract. Your blood vessels will contract. And if they contract too much, you will have vasospasm and ischemia, which brings um, the problem of causes all these problems. Okay, and these problems are exaggerated if the drug is given together with CYP3A4 inhibitors. Eh? I mean, there are many drugs that are CYP3A4 inhibitors. I don't remember the list. But for your purposes, try to remember lah. Try to remember uh, that this agonovin will be affected by liver enzymes. It will be affected by liver enzymes because these CYP3A4 inhibitors will inhibit the metabolism of ergonovin. So remember, if you inhibit metabolism, what happens? Less drugs will be excreted, more free drug will be circulating around and will cause effect at the target organ. So there are many drugs and antibiotics, for example, such as erythromycin. They are all CYP3A4 inhibitors. So if the patient is on erythromycin for whatever reason, being treated for an infection during pregnancy, and at the same time, after giving birth, she is given ergonovin, then you have to be really careful about these problems. It may cause a vasospasm. Okay. So as I mentioned just now, if you look at your textbooks, you will find ergonovin or being used interchangeably with ergometrin. Okay, and you can see here the effects of the different types of drugs on receptors. So ergonovin here mainly affects alpha adrenoceptors, okay, and also serotonin receptors, and has very important uterine smooth muscle stimulatory effects. Okay. Anyone remember bromocriptine? Okay, bromocriptine is in fact also an ergot alkaloid, but this drug is used as used for treatment of Parkinson's disease. If you remember your lectures on Parkinson's disease, so bromocriptine is used for the treatment of Parkinson's disease because it is specific for the dopamine receptor. So it binds directly to the dopamine receptor, stimulates the dopamine receptors, helps alleviate symptoms of Parkinson's disease in patients. Right, so go back to your textbooks, try to read about these drugs. Okay, this one is taken from Katzong. All right, those of you who joined us from AMU, the preferred textbook for pharmacology here would be Katzong. Okay, I don't know what is the latest edition. Even I am not using the latest edition, but the main textbook should be Katzong. So whatever you have learned in the lectures, please cross-check, cross-reference, read a little bit more in the textbooks, and the preferred textbook is Katzong. So number one, Katzong. Number two, if you have another textbook, Rang and Dale will be good as well. Okay, Rang and Dale. And if you are a really diligent student, like to read thick textbooks, you can read Goodman and Gilman's. Goodman and Gilman's. But this one actually technically just for reference. Definitely you don't have to read the entire book. Okay. Okay, I don't actually remember where I got this picture from, but this is a representation of what a drawing of so many years ago, in the 1500s or even before that, of people who are given ergot alkaloids, for not for pregnancy lah, for other reasons, and they develop ischemia of the extremities, which resulted in them having to amputate. They needed to have their extremities amputated. Okay, so remember this picture. Remember ergonovin. So remember this picture. Remember ergonovin causes cerebral ischemia. Cerebral ischemia, if not treated, causes patients' legs to be amputated. So something you don't want to happen. Okay, so again, this one you can read by yourself. This one is the use of prostaglandin as induction for or augmentation of labor. So it's a vaginal insert. Insert this into the vagina to start to induce the process of labor. And this one is a bit clinical lah, tak ada apa sekarang ni. Just the causes, factors, and which patients are vulnerable to hemorrhage. So you can read that up if you are interested. Okay, any questions up to this point? We are done with the first part of the first lecture. What time is it now? 8:50. I hope you can still bear with me. Any questions?
No, doctor.
Okay. How many are joining us tonight? Let's see if I list. Okay. Quite a lot of people online. I don't know whether you are listening or not lah. Maybe you are watching, I don't know whatever is on TV right now. Okay. Nevertheless, again, number one, I apologize for having to do this lecture now. Number two, more importantly, please refer back to your textbooks. Use this lecture as to complement whatever you are supposed to be reading in your textbooks. So, second part of this lecture, tocolytic drugs. Again, tocolytic drugs are drugs that cause the uterus to relax. Cause the uterus to relax. And why do we give these drugs? The main indication is for preterm labor, because you do not want the mother to be giving birth to a child before 36 weeks is up. Eh? I don't know if it's still 36 weeks or it used to be 37 weeks. But if I'm not mistaken, 36 weeks is quite okay lah actually. But anything less than 36 weeks, it's actually quite preterm. So you don't want the baby to be taken out before 36 weeks. So what are the drugs that can prevent preterm labor? Those are your tocolytic drugs. Okay, so let's go through them one by one. Okay, magnesium sulfate, we don't really understand how it works, but we postulate, most pharmacologists agree that the mechanism of action is via as a calcium antagonist. Most books will agree that the mechanism of action is as a calcium antagonist. And if you look at the picture earlier, you can see here where magnesium sulfate acts on. Okay, so magnesium sulfate will prevent the entry or antagonize calcium effects, and so you don't get calcium causing contraction. So this cascade here does not occur lah. So that's magnesium sulfate, acts as a calcium antagonist. How you give magnesium sulfate to the patient? Usually IM, 5 grams on the buttock on this side, 5 grams on this side. One you will learn later lah, when you do ONG. Okay, so it's usually given IM. Okay, and given IV, the onset is usually immediate. If given IV, with a duration of action of 30 minutes. Okay, if given IM, then it's going to be a little bit longer to take effect, but nevertheless, it is very effective for the termination of preterm labor. Okay, there may be side effects. Okay, but usually we don't see these side effects because usually we don't use magnesium sulfate as a prolonged treatment for preterm labor. There are better drugs that can stop preterm labor. Okay, so things such as fetal bone thinning or fractures due to decreased PTH ni very very rare lah if we use magnesium sulfate for the purpose of tocolysis. And how do you reverse magnesium sulfate toxicity? Anyone know? If a patient is overdosed with magnesium sulfate, the antidote drug is to give the patient calcium gluconate. Okay, calcium gluconate. All right, so that's magnesium sulfate. Number 2 is indomethacin. So number 1 is magnesium sulfate. Number 2 is indomethacin. Okay. How do they act as tocolytics? Indomethacin acts as tocolytics because they will block the formation of prostaglandin. So remember just now, prostaglandin is an oxytocic drug. It stimulates uterine contractions. Now we want to relax instead. We want to terminate uterine contractions, so we give something that can block the formation of prostaglandins, and certainly those drugs, NSAIDs, all of them will have effects on prostaglandin, but the one that we use as a tocolytic drug is indomethacin. So you've learned about indomethacin as well when we were discussing the non-steroidal anti-inflammatory drugs. Okay, so remember that indomethacin, if we use indomethacin, it will cause closure of the ductus arteriosus. So if you are using this drug as a tocolytic drug, remember that there may be premature closure of the ductus arteriosus. Drug number 3, I hope the drug is very familiar to you because we have learned about this drug before. Remember just now, the process of contraction is very much dependent on calcium and whatever calcium does at the cellular level. Okay, so it's very much dependent on the phosphorylation of myosin light chain kinase, myosin light chain, which is mediated by myosin light chain kinase, which is in turn needs to be facilitated by the calcium calmodulin complex. All these things we have learned before. Okay, so this process can be blocked easily by the use of calcium channel blockers. So nifedipine is a calcium channel blocker. Okay, since we have learned about nifedipine, what are the side effects that you would expect if someone is being given nifedipine as a tocolytic drug? Anyone? What do you think would be the side effects?
Excessive vasodilation.
Very good. Excessive vasodilation, because you are blocking calcium receptors in blood vessels, causing vasodilation. What else can happen? Where are the calcium channels located elsewhere? Okay, there are calcium channels in in the heart as well. So if you block those calcium channels, you may have negative inotropic and negative chronotropic effects. You get decreased heart rate and decreased contractility. So all these things you have learned before. So you can expect what would be the side effects if you use nifedipine as a tocolytic drug. So when you go back, please open your textbooks. This would be a very good time for you to revise what you have learned about calcium channel blockers as well. Okay. Next drug is terbutaline and also ritedrine. These are the two main beta-2 agonist drugs that can be used as a tocolytic drug. Okay. Anyone remember where we use beta-2 agonists? In what condition do we use beta-2 agonists and where are they found usually? Beta-2 receptors. Okay, I would be a bit worried if you don't know at this point of your lives, just a few months to go before professional exams. If you are not answering because you are not listening, then I'd be a bit more relieved. But if you're not answering because you don't know, I'd be a bit more worried. Anyone? Beta-2 agonist?
Is it to regulate blood pressure?
Not really.
Is
Beta-2?
it a bronchodilator?
Bronchodilator. So remember, beta-1 receptors we find in the heart, and we have drugs that stimulate beta-1 receptors to stimulate the heart, or we have drugs that block beta-1 receptors to slow down the heart, reduce the contractility. In what condition do you want to stimulate the heart? If the patient is collapsing, right? If the patient is in cardiogenic shock and you need to stimulate the heart, you give a beta-1 agonist, stimulate. If you want the heart to relax, you want the heart to slow down because the patient is hypertensive, for example, then you want to give a beta 1 antagonist. Okay, so that's beta 1. Beta 1 is hard. On the other hand, if it's beta 2 is smooth muscle, and what you have learned before, beta 2, the most predominant site would be your lungs. Beta 2 receptors in the lungs, and hence why we use beta 2 receptor agonists. They are used as bronchodilators. So remember, beta 2 agonists, bronchodilators, used for the treatment of asthma, COPD, and whatever condition that you need your lungs to be bronchodilated. Okay, so what has it got to do as a tocolytic? Remember, the effect of beta 2 is actually smooth muscle relaxation. So bronchodilation occurs because there is smooth muscle relaxation. So when we want to use a beta 2 agonist as a tocolytic, in fact, the tocolytic effect would be uterine smooth muscle relaxation. Okay, so uterine smooth muscle relaxation. Okay, what was the drug that was acting on alpha 1 receptors just now? Ergonovin. Ergonovin stimulates alpha 1 receptors in the uterine smooth muscle to cause contraction. Okay, but on the other hand, terbutaline stimulates beta 2 receptors in the uterine smooth muscle to cause relaxation. Okay, so for the drugs affecting uterine motility, remember, if it's contraction, it's alpha 1. If it's relaxation, it's beta 2. If it's contraction, it's ergonovin. If it's relaxation, it's terbutaline. So terbutaline is a beta 2 agonist. Beta 2 agonist. Okay. So that's my question there. Why is it contraindicated in diabetic mothers? But you can see the answer straight away in the next slide. So you can see when you stimulate beta 2 receptors, they will cause smooth muscle relaxation. So the main effect that you want with terbutaline would be smooth muscle relaxation in the uterus. But the problem that you don't want with terbutaline is the stimulation of glucose release. And this is a problem in diabetic patients. So not good for diabetic patients. Okay. So especially in patients who are in labor or who are in preterm labor, make sure that you take the history properly and be wary that there will be patients who are diabetic patients who undergo pregnancy, number one, or number two, there will be patients who are having gestational diabetes mellitus, GDM. Gestational diabetes mellitus. Yeah, I don't know if you have learned this in other lectures, but GDM is a condition where a mother does not have diabetes mellitus before, and in fact, they won't have diabetes mellitus after pregnancy sometimes, but they have diabetes mellitus during the pregnancy only, because of the physiological changes that occur. They only have diabetes mellitus during the pregnancy, and we call it gestational diabetes mellitus. And if these patients come to the ward with preterm labor, which is actually quite common, it's quite common to have patients with GDM coming to the ward with preterm labor, very common, okay? And because of that, you will have to be very careful if you want to give terbutaline as a tocolytic drug, because now you know, because terbutaline, what is the mechanism, you know the mechanism, and you know it may stimulate the release of glucose in people, and it will exacerbate the condition in people who are diabetic. Okay. Okay, so you can see on this side, you can see on this side, the drugs that can cause the the uterus to relax. Okay. Okay, I think this one is the same. You can work it out yourselves. Okay, and of course the okay. Why is this slide here? I don't remember. Okay. One important side effect with terbutaline, you can sort of predict what are the side effects of terbutaline already. Remember when we're talking about salbutamol so long ago, I hope you remember salbutamol, which is also a beta-2 agonist, but we use salbutamol as a bronchodilator. And one of the things that we discussed is that even though it is a beta-2 agonist, the selectivity for beta-2 receptors is only relative, meaning that instead of just going to beta-2 receptors, it may still go to beta-1 receptors, and also meaning that instead of going to the lungs, or in this case, in the case of terbutaline, just going to the uterus, it will also go to other places, such as skeletal muscle. Okay, so that problem will give rise to side effects. So for example, if you have stimulation of beta-2 receptors in skeletal muscle, what will happen? How will the patient, what symptom will the patient present with? Anyone? Beta-2 stimulation of skeletal muscle? Ada orang ke tak ada ni?
Ada doctor, but I don't know the answer.
Terus dia answer. Okay.
Doctor,
Yes.
is it increase in muscle mass?
Muscle mass? Not really, not muscle mass. But rather increase in muscle contraction lah. Okay, so if you have a drug that is supposed to go to beta-2, it's supposed to go to beta-2 receptors. In this case, it's supposed to go to beta-2 receptors in the uterus. Terbutaline ni, supposed to go to the uterus. But instead of going just to the uterus, it also goes to beta-2 receptors in skeletal muscle, and that causes contractions, and the patient will usually manifest as tremors. Tremors. It's very common also in the wards. So if you are starting the patient on terbutaline infusion for preterm labor, let's imagine your situation in 4 years' time. You are the houseman, okay? You ask the nurse to start terbutaline infusion for this patient. After discussing with your MO, patient comes in at 28 weeks, having contractions. You want to stop the contractions, okay, please start the patient on terbutaline. You already checked, the patient is not diabetic, so that's very good. Because you remember your pharmacology, you already checked, patient is not diabetic, so you can give terbutaline. However, after 4 hours, you were seeing another patient taking history for radiation. It's 2 a.m. in the morning, and suddenly the nurse calls you, doctor, patient is having tremors. So do you panic or not? If you know your pharmacology, you will not panic. So you will know that the tremors is caused by stimulation of beta 2 receptors in skeletal muscle. So do we see this? Yes, we do sometimes see this. Do we need to stop the drug because of the tremors? Most of the times, no. Most of the time, you do not need to stop the drug. Similarly, if the patient is on beta 2 agonist, on beta 2 on salbutamol in the ward, sometimes they get tremors because in the wards, we tend to bukanlah overdose, but we tend to give them a lot more than the usual dose. Those of you who have asthma, you probably will know. Just if you need to take salbutamol, it should not be more than every 6 hourly, 2 puffs, something like that, kan? But in the ward, sometimes we give a lot more than that, and sometimes yes, the patient will present with tremors. So, but usually it's not that life threatening, and it's not something that is life threatening. So we just continue. Okay. So similarly, if again remember, because the selectivity is only relative, so apart from just going to beta 2 receptors, it may also go to beta 1 receptors. Remember beta 1, remember the heart. So if you stimulate beta 1 receptors, you will have problems such as increased heart rate and increased contractility. So patients given terbutaline, also it is not uncommon for them to have slightly raised heart rate. They may be tachycardic. Okay, they may be tachycardic. Okay, now itu cerita lain sebenarnya. That's a different story. The thing that I want to stress on in this slide is actually terbutaline. One of the peculiar side effects that occur to patients who are pregnant given terbutaline because of preterm labor is the problem of, anyone know what is wrong with this chest x-ray? Not COVID, This is not COVID. Anyone know what is wrong with this chest x-ray?
It's not as clear as it should be. Like there's
Not
liquid.
as it should, because this is actually fluid. So there's actually a lot of fluid in the ni. In fact, ini pun sebenarnya fluid juga ni. So this is actually full blown pulmonary edema. Okay. Alright. How do you know if a patient is pulmonary edema? By percussion. What would be your finding?
Dull sounds.
Dull,
Instead of
stony dull,
yeah.
Stony dull on percussion. That's why if you go for CST with me, I will always check your percussion technique. Percussion is still very important in the wards. Not all the time you can just send the patient to chest x-ray, or tak tahu ni patient ni apa sakit dia. Just buat chest x-ray lah, no idea. Auscultate tak dengar apa, you cannot hear anything. Percuss, your technique is very bad, so you just send for chest x-ray. Sometimes you cannot send a patient for chest x-ray, such as this patient. If a patient is pregnant, patient is preterm labor, given terbutaline, you cannot send the patient to chest x-ray to confirm the diagnosis. Right? Can you send the patient to chest x-ray? No, because the radiation will be bad for it's teratogenic to the fetus. So you don't send a pregnant patient for chest x-ray. So how are you going to establish whether the patient is having pulmonary edema or not? Patient will be breathless. Urine output may be increased because there's a lot of fluid in the or decrease rather, because there's a lot of fluid that is being retained and not coming out from the kidneys. So there's a lot of fluid in the lungs. Okay, so this one we are not sure in terms of the mechanism, but it is a very important side effect in patients who are given terbutaline. In pregnant patients who are given terbutaline. So remember terbutaline, remember pulmonary edema. Okay, so last one for the tocolytic drugs, yeah, you have atosiban, and atosiban is basically just an oxytocin analog which acts as an antagonist. Okay, when you answer mechanism of action, antagonist, the full answer will usually be you need to know whether it's competitive antagonism or non-competitive antagonism. So atosiban, in fact, it is a competitive antagonist. Of course, because it is an analog. So if you see anything that, if it's an analog, usually the antagonism will be competitive antagonism. So for SAQ, make sure to get full marks. You should mention competitive antagonist instead of just antagonist for whatever drug that acts as an antagonist. Okay. If it's a competitive antagonist, how would it affect the log dose response curve? Let's say this is the log dose response curve. Log dose response curve. Okay. If it's an antagonist, how would it affect the log dose response curve? Anyone know? If you add an antagonist, would it look something like this? Or would it look like something like this? Nampak buruk pula. Okay, something like that lah. Okay, anyone know? Anyone remember from pharmacodynamics? Sometimes I ask this again in SBAQ, even though you are already in systemic pharmacology.
Second one, doctor.
Second one, competitive antagonism. Is it green one or blue one? The red one is normal agonist. So the green one, is it? Say again?
Green one.
Green one. So remember, if it's competitive antagonism, very good. Very good. If it's competitive antagonism, the graph, the log dose response curve will be shifted to the right. Because the efficacy will remain the same. It's just that the dose needed to reach that efficacy will need to be increased. Why do we need to increase the dose? Because the antagonism is competitive, meaning that if you have a lot of oxytocin around, and you have a lot of atosiban around, okay, they will compete for the same. They will compete for the same receptor. They will compete for the same receptor. So initially, atosiban will compete with the same receptor, and it will cause antagonism lah. It will inhibit the effects of oxytocin. But what oxytocin can do, because this is competitive antagonism, is that if you increase the levels of oxytocin, you can actually fight back. You can actually fight back against the antagonist, and you can still reach the same efficacy. It's just that you need to increase the dose. Instead of a lower dose here, you need to increase the dose to a higher dose to get the same effect. Because at this point of time, you have the antagonist fighting it out with you to get to bind to the same receptor site. Compare this to the log dose response curve that you get with a non-competitive antagonism where it's not just the dose that is affected, but also the efficacy is also affected. Because why? They are not competing with each other. They will be a non-competitive antagonist will be binding to somewhere else, and it will not be reliant. It will, what apa? Regardless of what you do to the number of agonists, it will still be able to inhibit the response. So you get a shift to the right and also downwards. Okay, this one is basic pharmacology, pharmacodynamics. Please revise if you have no idea what I am talking about right now. Because these things you should have learned in year one. I think your batch with Dr. Jahid kan yang ajar who taught you the pharmacodynamics. Okay. Alright, so do you need a break before we move on to the how many slides we have? Not too many, less than 20 slides. Do you want a break or do you
Yes,
want to
sir.
continue? Say again?
5 minutes break would be nice.
Okay, so maybe 5 minutes break. So
Alright, thank you very much,
let's say about 9:26. Okay, alright. So we'll have a break for 5 minutes.
Okay, Doc.
Excuse me, doctor. I think your mic is not on.
Yes, doctor, we couldn't hear you. I think your mic is disconnected. But you're not muted on Teams. I think it's hardware, your hardware.
Guys, I think he can't hear us either.
Sorry, I already contacted Dr. SD. You should be reading my messages right now.
Okay, can you hear my voice?
Yes, doctor.
Okay. Thank God, you told me after just a few slides. I think some of my friends said were only told after the lecture is about to end, or just like the case of the lecturer from Hong Kong, the early days of the pandemic. Students just left him to talk all by himself. Okay, so where were we just now? Okay, I'm not going to repeat myself too much because did you hear the beginning of the lecture? No.
No, doctor.
Okay, maybe I'll
From the
just
animal picture, we didn't hear you. We cannot hear
from
you.
the from the animal picture you didn't hear me
Yes.
when I was talking about apa ni the questions apa semua. You can hear me.
No. After the break, we couldn't hear you at all.
Okay. So I'll just repeat one thing. I was telling you just now. Okay, for this topic. Okay, for this topic, the don't have to worry too much about this topic. The main thing is about understanding general mechanisms of teratogenicity. Okay, that's number one. Number two, there will be examples of drugs that are teratogenic in this lecture. And those same examples will be the one that you will have to be a bit more worried about for this block. So for the reproductive system, you don't have to worry too much about knowing all drugs that are teratogenic. Just go through this lecture and look at the examples that I was discussing, and those are the same drugs that are going to come up in the exam. Number three, the number of questions is not that many also for this topic. It's only one question for mid-course, one question for end of course. Okay, and but number four, so but number four is a but number four, for the purpose of the first professional exam, once you have revised all your drugs that you have learned in year 1 and year 2, you should be able to identify which drugs are teratogenic, and if it is teratogenic, what are its teratogenic effects, and if known or if you are taught, what are the mechanisms of its teratogenicity. But that
Excuse
is
me,
for
doctor.
later. Yes.
Are you sharing the screen, doctor?
Oh, I'm not sharing the screen pula sekarang. Okay, tunggu.
Yeah.
Okay, but you understand what I you heard what I said just now, So those
Yes,
are
doctor.
How many things did I say just now? 4 or 5 things? Four things, is it? Okay. Most importantly, for this block, don't worry too much about the drugs. Just go back to this the notes that you were given, and look at the examples, and the questions will come from the examples only. Okay, so I'm sharing my screen again now. Okay. Okay, you can see my screen, yeah? Okay, so teratogenic. Okay, teratogenic means monster, hence the terato means monster, hence the previous picture that I showed you. Okay, remember that teratogenic is something to do with the developing fetus. Compare that with something that is being mutagenic, which is simply a mutagen, such as radiation, or something that is carcinogenic, anything that can cause cancer, things that you eat every day. Some of them will eventually cause cancer and things like that. But that can also happen at any point of time. Compare that to teratogenic, which is exclusive for things that occur in the developing fetus. Alright, for the problems that occur in the developing fetus. Do we understand how a drug is teratogenic? Not all the time, but the suspects, we have classified the suspects, and so it can be idiopathic, meaning that we don't know what's happening. Ionizing radiation can be teratogenic. So just now I was talking to you about something as simple as a chest X-ray. You don't want to do a chest X-ray to pregnant woman. All right, and of course other uses of radiation, such as for radiotherapy for cancer, okay, or things such as CT scan, which is the same as X-ray lah. So all these things, you need to be very careful if the patient is pregnant, or sometimes because the patient does not know if she is pregnant or not. So even nowadays, the standard operating procedure, if someone is asked to do a chest X-ray, for example, in the National Cancer Institute, they will always ask you to ask the patient to have to get a urine pregnancy test done, to make sure that the patient is not pregnant. Okay. Viral infections can be teratogenic. Okay. Drugs, which we are going to discuss in the next few slides, are of course teratogenic. Okay, and also of course alcohol and smoking, they are also teratogenic, although people do not want to listen, so they keep drinking alcohol or they keep smoking. Okay, the drugs definitely are the things that we are going to discuss in the next few slides. Things such as diethylstilbestrol, thalidomide. You can Google this up. Thalidomide, you can Google what actually happened many years ago, and how it gave awareness, how it raised awareness on the problem of teratogenicity, teratogenicity, and how drugs can be teratogenic. Okay. Okay, what are the factors that affect placental drug transfer and drug effects on the fetus? For a drug to be teratogenic, the main mechanism needs to be the fact that the drug is able to cross the placenta. Okay, for a drug to be teratogenic, the main method would be the ability of the drug to cross the placenta. Okay, so the rate at which the drug crosses the placenta and the actual amount of the drug reaching the fetus would be one of the most critical factors that affect teratogenicity. But also, of course, the physicochemical properties of the drug, such as molecular weight. If the drug is bigger, it's a bit more difficult to cross the placenta. Okay, the placenta itself, at what stage it is on, and at what stage of fetal development is it on, whether it's fully developed for the drugs to actually use it to cross into the baby, okay, into the fetus. The duration of exposure to the drug, okay. If you are only given a drug once off PRN, even though the drug is teratogenic, it is very unlikely that you will be getting any teratogenic effect. So, for example, if if a mother somehow gets a seizure during pregnancy, okay, but it's of unknown cause and it's just a once-off episode of seizure. She does not have a history of epilepsy. She's never been treated for epilepsy before. It's just a once-off episode of seizure, and that once-off episode of seizure was treated with, for example, IV phenytoin. Okay, just single dose. Okay, or just a single dose, and the patient is pregnant, but it's just a single dose. So that is very unlikely to give any teratogenic effect, because it's just a single dose and it's very short duration of exposure to the drug. Despite the fact that phenytoin and most other anti-epileptic drugs are all teratogenic. So it needs to have a certain degree of exposure as well. And of course, the distribution characteristic of the drug in different tissue, and depending on which tissue will be affected. Okay, so factors affecting teratogenicity, pharmacokinetics, drug's passage across the placenta depend on lipid solubility, degree of drug ionization. Okay, so for example, a drug that is lipophilic, such as thiopentone, okay, which is used for general anesthesia and for sedation, it can cross the placenta and it can enter the fetal circulation and it may cause sedation and apnea. Okay, whereas drugs such as succinylcholine and tuberculin, which are skeletal muscle relaxants, they are only able to cross the placenta slowly, hence their concentrations in the fetus is low. So you are not worried about this drug lah. So it depends on lipid solubility and degree of drug ionization. Okay, molecular weight also an important factor. Influences the rate and amount of drug transferred into the placenta. For example, heparin versus warfarin. Okay, which one has a high molecular weight? Which one has a low molecular weight? Anybody know? Heparin versus warfarin. Which one is more teratogenic? Which one is teratogenic? Anyone? Okay, warfarin is a lot more teratogenic compared to heparin. Okay, because warfarin has a lower molecular weight. Because of that lower molecular weight, warfarin is able to cross the placenta and cause a host of syndromes called the fetal warfarin syndrome. So remember warfarin, remember fetal warfarin syndrome. When you refer to your textbooks later on, please read up the fetal warfarin syndrome. Compare that to heparin, which has a higher molecular weight and does not cross the placenta as much as warfarin. Hence, it is not teratogenic. teratogenic. Okay. Next factor affecting teratogenicity is whether the drug is bound to plasma protein or not. Remember, if a drug is bound to plasma protein, it does not go anywhere. It remains with the plasma protein. But if a drug is less bound to a plasma protein, okay, the drug will tend with what we call free drug. Okay, and that free drug will tend to go to the target organ. In this case, drugs that are not bound to the plasma protein will be able to cross the placenta and cause teratogenic effects. Okay, so those are the factors, factors that affect teratogenicity. And here you can see the different time periods that can affect, that can cause teratogenic effects in the developing fetus. The most critical point of time is actually the stage of organogenesis. The most important stage is actually the stage of organogenesis. So 17 to 60 days, this is the most critical time point. So teratogenic drugs, if given at this time point, will cause problems. So teratogenic drugs given at this point of time will cause definite problems. Okay. All right. So on the other hand, before that, you have cytotoxic drugs used for cancer or alcohol may cause problems with cell division, but it will not cause teratogenicity in the actual fact, because the developing fetus will only die off, because it's technically not even it's technically not even a fetus yet lah. Or if something else happened after that, then the effects are, well, there will still be teratogenic effects, but it's not as pronounced, or it's not as bad as what we would get if a teratogenic effect is given during the process of organogenesis. Okay, so you can see here the organs, okay, and the time period in terms of embryonic period and where it would be affected. So neural tube defects, you can see in weeks 3 to 4, or for the CVS, things such as ventricular septal defect or atrial septal defect, they will occur in around that time as well, 3 to 6 weeks, 3 to 6 weeks. Okay. Development of limbs, okay, things that happen later on. As an example, the teeth or the palate, cleft palate, it happens a little bit longer later on, 7 to 8 embryonic periods. Okay, so you can see what will happen in terms of the effect to the baby. But then again, still the most important time period is usually between 3 to 8 or 3 to 9 weeks. Okay, this point of time here, which is the period of organogenesis. In terms of the mechanism of teratogenicity, there are many mechanisms that are postulated. One of the more important ones is the effect of these teratogenic drugs on folate metabolism. But there are also drugs that cause neural crest cell disruption, okay, drugs that mess with your endocrine hormones, drugs that cause oxidative stress, drugs that cause vascular disruption, such as ACE inhibitors, they may cause vascular disruption, and drugs that target specific enzyme or target specific receptors. So going to the first example, you can see here two of the drugs that you have learned before. Anyone can tell me what are these drugs? Sulfonamide and trimethoprim. Do you have anyone online?
The antimicrobial drug, doctor.
Yeah, they are antimicrobial drugs. They are antimicrobial drugs. Okay, and the thing about sulfonamides and trimethoprim, as a matter of fact, is that both these drugs are usually given for UTI, urinary tract infection, and they act by inhibiting these two enzymes that are responsible for the formation of folate in bacteria. Okay, but because of that, it may also affect folate metabolism in humans, and because of that, it may also be teratogenic. And the fact that these drugs are given for UTI, sometimes doctors they wrongly prescribe these drugs for women who are pregnant, and for the same women who are pregnant and who are also having UTI, because they don't know that these drugs may be teratogenic. So something for you to think about. Okay, so you should remember these drugs. We have come across these drugs before when you were learning about the different drugs that act as antibacterial agents. Okay, you have come across this syndrome before, the fetal Hydantoin syndrome. What drug causes the fetal Hydantoin syndrome? Anyone? Okay, the clue is in the name. Hydantoin has the drug that causes the fetal Hydantoin syndrome is phenytoin. What is phenytoin? Phenytoin is an anti-epileptic drug. Okay. Okay, and these are the features that can be present in the baby when their mother was given phenytoin in pregnancy. Okay. Remember that there is only one drug, one anti-epileptic drug that has been proven to be safe for use in pregnancy. Anyone remember what that drug is? Okay, of all the drugs that anti-epileptic drugs, almost all of them are unsafe to be used in pregnancy. You have to have a risk-benefit calculation to really prescribe those drugs in pregnancy. But yes, there is one drug that is safe for use in pregnancy, and that is lamotrigine. You can go back to your textbooks, revise what lamotrigine is all about. So sometimes if you have the choice to give lamotrigine, if the case of epilepsy is not too bad, you may choose to use lamotrigine instead, which has been proven to be safe for use in pregnant women. Okay, and this is an example of a drug that causes another teratogenic effect. Anyone know what this drug is? This drug causes deranged vitamin K metabolism. Okay, so vitamin K metabolism, the drug that you have learned before, this drug is warfarin. Warfarin is a vitamin K antagonist. That's quite a simplistic mechanism of action lah. But if you revise your notes in hematology, you should be able to remember the VCOG enzyme and all those things. Alright, so warfarin is a vitamin K antagonist, and because of that, because of the deranged vitamin K metabolism, it is thought to give rise to this condition known as chondrodysplasia punctata, which is abnormal calcification in the cartilage of developing bones, okay, giving rise to this kind of appearance in the baby. Okay, so the most important period that we are concerned with, as I mentioned just now, is the period of organogenesis, which is up to 9 weeks. Okay, but onwards, it's no longer too much about organogenesis, but you can still have problems. So problems such as if you give ACE inhibitors to the mother, it may cause renal tubular dysgenesis in the baby. If you give these two drugs, which are NSAIDs, okay, if you give it to the mother, it may delay onset of labor and in the fetus cause closure of the ductus arteriosus. Remember, indomethacin cause closure of the ductus arteriosus. Hydroxychloroquine and chlorpromazine may be concentrated in the fetal eye, causing cataract. You remember hydroxychloroquine, President Donald Trump's favorite drug, thought to be effective against COVID, but definitely not lah. Lithium and tetracycline. Lithium is a drug that we use to treat depressive and manic symptoms in psychiatric patients. Okay, bipolar disorder. Tetracycline is an antibiotic. I hope you remember, can cause teeth and bone deformity. Vasoconstrictors can cause fetal distress by reducing uterine blood supply. Okay, fetal distress in this case means that you need to have a look at your CTG just now and look at the fetal heart rate. Okay, beta blockers may impair fetal response to hypoxia. Okay, all right. So you can go back to your notes and see how read about how this actually happens. Sulfonamides, another antibacterial drug. Okay, may displace bilirubin from plasma proteins. Okay, hence, okay, if it's bound to plasma protein, bilirubin is not a problem. But once it is displaced from its plasma protein, bilirubin is technically a free drug. So it acts like a free drug and it causes effects. So in this case, it causes jaundice. Jaundice. Jaundice itself is manageable, but when you have something as bad as kernicterus, if you don't, those of you who don't remember what kernicterus is, please go back to your textbooks. Jaundice itself is manageable, but once you have kernicterus, it's a big problem, especially for a newborn fetus. And babies born to mothers dependent on opioids may show a physical withdrawal syndrome. So remember, in the nervous system, you learn about opioids, and you learn about mothers who are given opioids. For example, in labor, if you give opioids in labor, it may cause respiratory depression in the newborn. The drug is given to the mother, but the respiratory depression is affects the newborn. So baby is non-responsive. So what you need to do as a house officer, you need to be able to identify that, and you need to ask the nurse to prepare a naloxone injection for the newborn baby. What is naloxone for? Naloxone is an opioid antagonist. Okay, I hope you remember all these things now, because we have learned all this. We have learned about naloxone, we have learned about how to reverse opioid toxicity. We have also learned about the fact that mothers in labor who are given opioids, their newborn babies are very much at risk of opioid toxicity manifested by respiratory depression. Okay. And other things, diazepam, general anesthetics, you can read about this in the books. Okay, again, just examples. I hope when you get the time to read your textbooks, you take the time to read up a little bit about the effects that it may cause in the developing fetus and subsequently in the newborn fetus once they are born. What are the problems that they may be faced with. Okay, so the last two slides is nothing much. Okay, so now this is actually the old FDA. FDA stands for Food and Drug Administration of the United States. The old FDA classification system for teratogenic drugs. So we used to classify teratogenic drugs to category A, category B, category C, D, and X. X means that it is totally contraindicated in pregnancy, and the others depend on the level of evidence that is shown. So, for example, things such as thyroxine, if you have hypothyroidism, you may be treated with thyroxine, and that drug is definitely safe for human use because it has been shown in controlled human studies that it is not teratogenic. Paracetamol, okay, no human data, as a matter of fact. It's never actually it's never been done as a large study, but because we know it's safe, animal studies shows it's safe, so it's under category B. Okay, category C, actually animal studies are not okay. With no human data, risk cannot be ruled out. And this, for example, is morphine. Morphine is one of the most important analgesic drugs. Okay, I'm not talking about illicit morphine use as a drug user. No, as this one is for treatment in the hospital. It's very important as an analgesic drug. So even morphine is only under category C of the old FDA classification system. You have anti-epileptics that are in category D, which is where there is positive evidence of risk. However, sometimes we still use if the benefit outweighs the risk. We still use if the benefit outweighs the risk. And category X, this one is totally contraindicated. Totally contraindicated in pregnancy. Okay, but this is in fact the old classification system. There is a new classification system started to be used in 2015. Now it's already 2022. It's been 7 years already, but the use is still gradual. So old drugs, they may still not reflect the new so-called labeling system, but new drugs, they would have used the new labeling system. So nowadays it's not as simple as just classifying the drug as category A, B, C, D, or X. It's no longer like that, but the labeling will actually include explanation on why that drug is safe or not to be used in pregnancy, to be used in lactation, or to be used in other conditions involving females and males who are in their reproductive ages. So it's a bit more complicated lah, in terms of it's not as easy as just classifying something as category A, B, C, D, or X. But you need to go through the fine print, read through the pharmacology, and decide whether this drug, if you want to use in your patient, whether it is safe, or even if it's not that safe, whether the benefit would outweigh the risk. Okay, so any questions? Okay, I'll have to assume that I've lost all of you.
No question,
Yeah,
doctor.
no questions, doctor.
No questions, Okay, but otherwise, as I mentioned, already, so 3 topics from me, for this block. There will be another topic that will be taken by Dr. Ganesh. I think it's next week, on infections in the reproductive system. So there will be a total of 4 topics from pharmacology for this block. So please make sure you make the effort to cross-reference everything that you have learned in the lectures with your textbooks. Inshallah, the questions will be, it's not going to be too bad.